Okay. Hi, everyone. Thank you so much for joining today's webinar. We really appreciate you all taking your time. It seems like we have a great turnout, so that's amazing. So welcome to the WeMove Adolescent Health webinar hosted by the Desmond Tutu Health Foundation and Ivy. My name is Uchoma Wozur, and I'm an assistant professor of implementation science, Wake Forest School of Medicine. My research mainly focuses on HIV prevention as well as the use of mobile technologies for young people. And I have the honor of chairing this session. So as I said again, so thank you all so much again for joining. And we're looking forward to a very interesting as well as an interactive session. We have a great lineup of speakers as well as panelists. And just for some context, this is the second of the 6 webinars in the year. And today we're going to be focusing on adolescents, looking at mobile health, digital tools, as well as strategies on how they relate to each other. And for today's talk, we're going to hear from Dr. Aoife Doyle and Ms. Dominica Dhakwa. And in between that, we're going to have an artistic interlude from Yvonne. And this will be followed by a panel discussion where we're going to have speakers join us. Specifically, we're going to have Leah Ogada joining us, as well as Victoria Wabrimu and Lauren Finn. So to start off, we're going to ask a little bit of some questions just to get a sense of where we are in terms of gauging what our thoughts are when it comes to mobile phone applications and the use for adult and its use in adolescent health in low and middle income countries. So please, if you could take a few minutes to respond to that. And following that, we're going to share everyone's responses to those questions. So right now, I think that those questions should probably be in the chat box. Or no, we have the poll available to folks. So I'm going to just proceed with our first talk. So for our first talk, we have an amazing speaker. We have Dr. Aoife Doyle. She's an associate professor in the MRC International Statistics and Epidemiology Group at the London School of Hygiene and Tropical Medicine. For the past 18 years, her research has mainly focused on the health and well-being of young people. And she is currently based full-time at the Health Research Unit in Harare, Zimbabwe, where she leads the design, implementation, and evaluation of Y-Check, a novel adolescent health checkup strategy. And the title of her presentation is Adolescents, mHealth, Digital Tools and Strategies. So without much further ado, we're going to listen to Dr. Doyle's presentation on mHealth and adolescents.
Hi everyone, my name is Aoife Doyle and I'm an adolescent health researcher based here at Harare, Zimbabwe at Zim, but I also work at the London School of Hygiene and Tropical Medicine. And I'm here today to tell you a little bit about some of the work that we've been doing in the field of digital health among adolescents. So in my talk, I'm going to firstly talk a little bit about the patterns of access to digital media among adolescents and why is understanding this important for interventions. Next, I'm going to talk a little bit, very briefly, about the design of adolescent digital interventions, which of course could be like a 2-hour talk. And then finally, just to give you a little bit of our experience with 2 interventions that we've been developing here, one called Shvatanoda and the other called Y-Check. So firstly, patterns of access. So a useful framework, which I find when thinking about access, is the 5 A's of digital access, which was published by Tony Roberts in 2016. So the first is availability. To whom is the technology available, but importantly also unavailable? Is the technology affordable or unaffordable? Awareness, who is aware of the technology or unaware? And ability, so who has and doesn't have the skills to make effective use of the technology? And then finally, accessibility. In which languages is the technology accessible, and can people, for example, with physical impairments, use the technology? So as you can see, access is more than just having a mobile phone. It's also being able to use the phone for the purpose that it is intended. So there's some useful information globally on access and use of technology from the ITU organization. If you go on their website, you can see lots of interesting facts and figures. These infographics I pulled from that website, which is based on data in 2020. So on the top graph, you can see the generational gap. So on the left, the column on the left in each of these regions is youth access. So the percentage of individuals using the internet in 2020. And on the right-hand side in each region is the use among those who are not young people. And you can see that across the board, there is higher use among adolescents and young people, which is what you might expect. But you can also see that there's quite a lot of regional disparity, whereas in Europe, for example, 97% of young people used the internet in the last year, whereas in Africa, this figure is estimated to be 40%. In the bottom graph, you can see what they estimate to be the difference between urban and rural areas. So here you can see it's very stark, especially in places like Africa, where in some rural areas access is very, very low. But across the board, there is lower access in rural areas. So even though over time access to good network and internet is increasing, you can see that there's still quite a lot of divides that exist out there. And so when designing interventions, it's important to understand your particular context. So we faced this issue when we were writing grant proposals to do some digital work with young people in Zimbabwe. There really wasn't much data available, and the donors were asking difficult questions about how many people use phones and why do you think this might be feasible to do what you want to do, and what is the safety and who do they share phones with, and lots of important questions. So this inspired us to do a bit of work around this. So we did a cross-sectional survey in 2018. And we found that, in fact, among our population of 13 to 24-year-olds, 63% did, in fact, own a phone, and an additional 4% had access to a shared phone. So access was pretty high. And access started at quite a young age. So in males aged 13 years and females 15 years. 3/4 had ever used the internet, but 1/4 had not. So while we might think, we could do an intervention on a smartphone, for example, we would then be missing 1/4 of the population. And interestingly, access was higher among males than females for internet use, whereas there wasn't much difference among males and females for phone use. Among those who didn't have a phone, we tried to understand what were the main barriers, and 22% reported cost as the main reason for not using a phone. We were also asked quite a lot of questions around what they use their phones for and what they enjoy using their phones for. And 26% said that they'd already sometimes use their phones to access health information or services. So based on this, we felt that some kind of digital intervention would be potentially feasible in this population of young people, though there would be a proportion of young people who would not have access to the intervention. So what kinds of things, in addition to understanding the context, what kinds of things are important when designing digital health interventions? WHO and partners published this guidance in 2020, which I think is quite a useful overview for those trying to develop an intervention for the first time in this field. Importantly, and not surprisingly for any of us working in the field of adolescent health, is that they recommend that young people should be included at every stage of the process. And we have tried to do this in our work here, and we find it really beneficial, as you'll see later. Very interestingly, I think, is they make the recommendation that digital is not always the best choice. And I think this is based on a number of factors, but one of them must be access. So I do think it's worth thinking about this, that as our world becomes more digitally enabled, it's not the only tool that we have in our box. And they also recommend that it's better to reuse than reinvent. So if there's something interesting and innovative and potentially effective in South Africa, potentially we could adapt it for use in Zimbabwe and vice versa. And also digital health is not a silver bullet. The origins of this, I think, is in when digital health interventions started, there was a great enthusiasm at the great potential of digital health and that it may help solve some of these challenges that we faced over the years, you know, challenges with delivering health services and changing behaviors and trying to work within challenging social norms, etc. But I think digital health will face the same challenges. It's just a different way of trying to address those. So in their guidance, they have this useful diagram, I think, where they divide it into 3 phases. So planning, the first step being the landscape analysis and needs assessment, which is partly draws on the kind of data that I was showing you earlier, like who has phones, what do they use them for, what are the barriers to using them. And then the next question they have is digital optimal? So if you decide it is, they recommend that you use a theory-driven approach. So you think carefully about a framework for your intervention and what behavioral change theories or other theories that you're going to build upon. And then there's a developing phase. And I think for some of our interventions, we're in this phase where we're prototyping, we've tried something and now we're going to try something again. And this phase is a phase where you simultaneously work on improving the content, but also the delivery. And then there's an implementation phase, which is also a phased approach with some monitoring and evaluation and no doubt some improvements along the way. So that's a useful document if you're interested. So now I'm just going to, in the last part of my talk, give you a couple of examples from Zimbabwe. The first is a project called Zvatanoda, which means what we want. And this was a project that was led by Aoife, the Organization for Public Health Intervention and Development here in Zimbabwe. And they had a pilot intervention which they were interested in doing some more work on and doing some more rigorous evaluation of. So we got some funding to do a feasibility study, and we joined partnership with the SHM Foundation, who had already some mobile phone-based chat interventions in other settings. And our aim was to increase the demand for an uptake of health services by 18 to 24-year-olds in a city called Chitongwiza, which is near the capital, Harare. So we formed 4 groups of young people, and we gave them phones, and we invited them to participate in peer-facilitated discussion groups over a period of 13 weeks. And each week there was a weekly topic that they discussed. The topics ranged from violence, mental health, substance use, HIV, sexual reproductive health, cervical cancer screening, etc. So they participated on a platform called Rocket Chat, which is an anonymous platform where they use pseudonyms. So they didn't use their real names. But the app was downloaded onto a phone, so it operated a bit like WhatsApp, but with this level of anonymity. We also, at the end of each week, had an expert come in and chat about that particular topic. And what we were aiming to do was for young people to not only increase their knowledge, but also come up with some commitments in terms of their access to services and some recommendations and feedback to service providers, who create a dialogue between these two groups, which traditionally have not had a strong level of communication. So I'm just going to share some of the findings in relation to the use of mobile phones in particular. So in the mobile phone chat groups, they really value the privacy, so using this Rocket Chat platform. And you can see here one of the young people in the group said that if you're using pseudonym names, I feel free to say anything I want. So this was reducing a barrier and allowed them to discuss some of these health topics quite freely. Interaction and use chats within the groups had a good level, but there were some people who struggled to participate at the agreed time for the chat, partly because they were in school or they had some network challenges. So even though they had phones, that the project had provided them on the basis of this feasibility study, they still had problems accessing the network in order to participate. And some of the young people had problem charging the phones because of cuts in electricity, etc. And one interesting finding that we did not anticipate was at the end, some of the feedback from the young people reflecting on the process and how they enjoyed it and what they would recommend going forward. They thought that maybe after a few weeks of the digital discussions, that maybe some face-to-face discussions would be useful. And this was in the context of COVID. So the phones allowed us to implement the intervention during COVID restrictions, but perhaps also the desire for face-to-face discussions came out of the fact that there was so little going on at that time. But it's interesting, and it's something we're reflecting on going forward. And this next project is called Whitecheck. So this is a new project it's an intervention that we're developing in collaboration with the RTI and with partners in Europe at WHO and in Ghana and Tanzania. And the idea is to deliver a health and well-being checkup visit for adolescents. And in order to do this efficiently and engaging the young people as much as possible, we have decided to create an app. So the intervention starts with a young person self-completing a series of questions around their health and well-being. And the study team then enters some measurements into the same application. And then all the data is summarized, and any issues that are flagged are then flagged for the nurse and counsellor on our team to discuss with the young person who is still at the checkup visit. So we needed to use an app or something digital so that the information could be quickly summarized and any issues flagged. But what we found was that we originally thought we might use ODK, which is a great platform, but it's hard to modify it to make it as youth-friendly as we wanted to. So we decided to go down the route of developing an app. And not lightly, I don't know how many of you have developed app, but it's not a very straightforward process. So we're working with a great team of programmers and with a design team as well. And just to give you an idea of the level of complexity, this image here is an early diagram of hand-drawn diagram by my colleague here, trying to understand the different screens that we need on the app and how they're interconnected and how the data will move between different aspects. So we did, as recommended, we've been working closely with adolescents to design the intervention, and I thought it was useful to share some of our lessons learned and the kinds of things, like real examples of why it was useful to do this. So we had a couple of workshops and some other informal feedback during pre-testing and piloting. And the main feedback we got was on the appearance of the app and the flow. So did they like the colors? Was it easy to go from one page to another? How appropriate were the images? What about the wording of the questions? Which questions did they find difficult or hard to understand? And also we had at the end, so the questionnaire had 8 to 10 sections. And at the end of each section, we have like an animation to sort of cheer them on and say, well done, you finished section 1, keep going. So at the first thing I'd like to share with you is, well, on the right at the top, this is an example of what it looks like. So we've tried to have one question per page, tick boxes, and then this little rocket at the bottom, so it goes along in each section so you can see the progress that you're making. And so, you know, mostly the feedback's been quite good. There's been some preference for some of the questions. They say it would be better to have a photo, and for other questions, they say no, an animated picture would be better. So we've got a mixture of photos and animations. So on the left-hand side, you can see one of the questions we're asking is about body image. And this image, we got feedback from several, not all, but some of the young people, and also from other stakeholders saying that these images were too revealing. So we are considering changing these. I think in this case, the shorts on the boys was too short. So these images were drawn by our Zimbabwean design team. So I think it just shows you that even within the same context, what might be appropriate in one setting is not necessarily appropriate either in a different setting or in a different age group. And then the last thing I'd like to share is this animation. So on the left with this rocket and this cup. So this was designed by some of our team. And it's sort of like the rocket moves along and it goes, well done, you finished this section. And when we have two age groups we're targeting, so 10 to 13, and then in primary school, and then 15, 16, 17 in secondary school and in community settings. And the younger ones loved this, they thought it was great. And the older ones, they thought it was too babyish and that this was just for kids and they didn't really like it. So we're now working on this second animation on the right, which is a bit more graffiti with just the words congratulations or some other words to tell them well done, keep going. And so we're hoping we're going to test this soon, next week, I think, at a workshop to see whether this is more appropriate and acceptable. So I think I'm just going to finish here with a summary. So firstly, understanding the context, so that access is definitely increasing to digital technologies, but inequalities exist. And then designing with young people and other stakeholders, designing with diversity in mind. So I think this is something that's really struck me in the work that we've been doing, especially with YCheck, is while we're dealing with this 10 to 19-year-old population, there is a world of difference between some of these adolescents in terms of not only their preferences, but also the skills and the language and literacy levels. And then, as you saw in the images and the feedback we've got, some very different beliefs about what is appropriate and what is not appropriate. So I think design with diversity in mind and try to adapt as much as you can to different preferences. Digital is not always best, as you saw from the Schwarzenegger example. It worked quite well, but the suggestion then is maybe to do a bit of a mix of digital and face-to-face. And one reflection that I had when preparing this is that, this is moving so fast that when you're designing, especially in the research field where our timelines sort of spread over 2, 3, 4, 5 years, when we're designing interventions now, are we designing for now or designing for the future and how things are going to change? So I think in terms of mobile phone use, for example, even if not all young people have access now, can we anticipate that the access levels will increase? And by 3 or 5 years time, the access levels will be very high. So just some things to think about, and I look forward to any feedback or discussion later. Thank you.
Thank you so much, Dr. Aoife, for your presentation. It was a wonderful talk. So she took us through the landscape of digital health in sub-Saharan Africa and also talked about some lessons learned with real life examples. So what are some of the opportunities? What are some of the barriers? As well as what are some of the things that worked? And also, as you have questions, feel free to put it in the chat. And at the end, we're going to have opportunities for our speakers to respond to some of the questions we may have. And so back to what we wanted to do initially. So our poll is finally working. So if you can take a little bit of a minute just to respond to the question that comes up, that way we can gauge what our perceptions are in terms of the use of mobile health application for adolescent health in low and middle income countries. So we're going to take a minute to do this and we can continue. So the next on our agenda, which is pretty exciting. So we have an artist coming up soon, Yvonne, but once we're done with this, I'll introduce her properly. So, okay, so I think we've all had enough time to complete this. So thanks everyone for taking the time to complete the poll. Will help us to get a sense of where we are. So from the responses, it shows that majority of us actually agree or strongly agree that mobile applications have become essential to adolescent health in low and middle income countries. And a few of us disagree and we have some neutral. So no one strongly disagrees. So it just shows that there has been applications or some successes when it comes to mobile health application. But from the talk we just had today, sometimes it might not be digital health or it might not be mobile health. So thinking about some of those contextual factors that might influence what type of program or what kind of intervention we create. So thanks everyone for this. This is very helpful to get a sense of where we are. So moving forward, so we have a little bit of an interlude. We have a wonderful artist today in our midst who will be sharing or who will be expressing. We're researching most of the time. We think about the academic stuff, but no, we have Yvonne. She's a Cape Town-based artist who uses multimedia to express her different forms of art, and we'll be providing an interpretation of today's topic. So I'm gonna let Yvonne take it away.
Hello everyone. Hello everyone. My name is Yvonne Msebenzi. I am based in Cape Town. Ngomabhayilo, uKhetsha, umSuthu. Inyuka emnyama ecandiziziba. I'm an artist, a graduate from Magnet Theatre. I'm a theatre maker, I'm a musician, I'm a puppeteer. I'm also active in society where I'm coming from to make a change in young people of today. Growing up, it was really a challenge for me as a teenager to sit down with my mom and talk about these things. It was not easy at all. It also has to do with the community where I'm coming from. It also has to do with how they were taught. And it was not easy for her. I'm here today to rearrange the mentality of society, to rearrange the sexuality of the contraceptives, to rearrange the saying of the people who use contraceptives as an ohat. I'm here today to rearrange the mentality of our society, that when I walk into the clinic dressed in a particular way, it is not an immediate call for a sexualized judgment. The judgments get worse when we enter the premises dressed in a particular way. And it has digital world excuses us from the judgment. We can be in our comfort of our own home, wearing whatever we want, and be able to book our appointment through the digital. Growing up, we lacked the privilege of being able to sit with our elders, where we received knowledge about women's health. But because the digital world, we are able to access information and feel our knowledge. Women utilized media, including the internet, as an additional source of information. Social can be our health mentors, where when we are unable to ask for guidance and questions, we run to the internet to clarify and get the method. When young women cannot rely upon advice about contraceptives, method from family, then the socials and internet is always opened. We can read it to welcome them with an open hands. Ixesha lenkululeko, ixesha lenkululeko, ixesha lenkululeko, ayalisafani nelasemandulo. Ixesha lanamhlanje ayalisafani nelamandulo, nelamandulo. Izinto azisafani, ayazisafani izinto. Namhlanje zilula izinto, namhlanje izinto zilula. Ngoko ke masingoyiki, hayi masingoyiki.
That was a wonderful interpretation of thinking about sexual health in general. For me, that was actually amazing, given that that is a different way for us to think about health. So there are other creative ways, you could communicate health, and we had this wonderful expression of that. So thank you so much, Yvonne. That was amazing. So next we have our second speaker. And also in the meantime, just a reminder, we have the the option for you to send in your questions so that at the end of our next speaker, once we're ready for the panel discussion, those questions can be responded to. So the next speaker we have, our second speaker for today is Ms. Dominica Dhakwa. She's the Chief of Party for the Dreams Rise project and is based at Zimbabwe Health Interventions. She has been responsible for programs that focus on mobile health interventions that improve adolescent sexual and reproductive health outcomes. And the title of her presentation is The Use of Mobile Health Solutions for Improving Access to Adolescents' Sexual and Reproductive Health in Resource-Limited Settings, Lessons from Zimbabwe. So the next, okay, we're ready.
Thank you very much for the kind introduction. So Zimbabwe Health Interventions is a human development organization whose thrust is to provide innovative and sustainable solutions to society's health challenges. And today I am going to share with you some of the lessons that we have learned using mHealth solutions for improved access to girls and young women's access to both sexual reproductive health and HIV prevention services. This is the presentation outline. I'll give a bit of a background overview of the program. In summary, the DREAMS referral protocol and what were the aims and objectives of our assessment and what the results and conclusions were. So the DREAMS program is a program that is being implemented in more than 12 African countries. This is an HIV prevention program whose goal is to reduce new HIV infections amongst girls and young women aged 10 to 24, and is responding directly to evidence around the increased the continuous increasing of new HIV incidents amongst this subpopulation. What is important to note about the DREAMS program is that in terms of its approach, it goes beyond just the biomedical interventions to addressing the social and economic determinants of health. But most importantly, it puts the adolescent girls and young women at the center of addressing the challenges that increase vulnerability and susceptibility to HIV infection. So in our program, we have this referral protocol because we have multiple service providers and multiple entry points. And we are working with young people. You know, we were, before introducing the referral protocol and mHealth, we were experiencing a lot of, you know, our completion rates were very low. When I speak of completion rates, I mean, you know, we have this DREAMS package of services, but most of the adolescent girls and young women that we were working with were not completing, you know, accessing all the services according to their needs, according to the profiles, to the profiles, because at entry point, we profile the adolescent girls and young women. But we have seen, for example, we have implemented both a paper-based referral system and also the mHealth, which involves digital capturing and follow-up of referral slips that are issued in the referral process. So what was the aim and objectives of our study? Basically, we aimed at assessing the use of mHealth solutions in improving completion of referrals amongst the target groups. We had three objectives. Number one, to assess the effectiveness of mHealth in improving access to adolescent sexual reproductive health and HIV prevention. The other objective is that we wanted to evaluate the turnaround time for referral completion, using both the paper-based and the mHealth platforms. Then lastly, to explore factors associated with services referral completion amongst the target group. So in terms of design, this analysis used aggregated and routine program data extracted from we have a common database, DHIS2 database for all the consortium partners. The study population, we targeted adolescent girls and young women who had been enrolled into the program and referred for HIV testing and counseling services, as well as adolescent sexual reproductive services, using both the paper-based referral system, and we're looking at that period October 2018 to September 2019. And for mHealth, we were looking at October 2019 to September 2020. And we did this in 6 high priority high HIV burden districts in Zimbabwe. In terms of sampling and data collection, our sample with those girls and young women are referred for those services. In terms of data analysis, we use the chi-square test. We also used logistics regression in order to estimate the factors associated with service completion. We also did survival analysis. Last but not least, we also used Cox proportional hazard analysis in order to test the difference in time completion of service referral between the 2 platforms. So what were some of the findings? So a total of 8,800 girls and young women were referred for HTS and ARCH services. 59.5% were referred through mHealth, 50.5% through the paper-based system. But out of this, 95% that were referred through mHealth and 80% referred through the paper-based system were single. What we established was that there were more referrals, 95.2% through mHealth, which were completed, than compared to 87.8% through the paper-based system. Also, girls and young women who were referred through the mHealth platform were 17.9 times more likely to complete referral, which means to access all the services according to their profile, than those that were referred through the paper-based system. We also established that adolescent girls, young women were 75.2 less likely to complete service referral than those that were a bit older. So there are age dynamics there. We also established that girls and young women who were single were less likely to complete referrals than those that were married and divorced. But I think when we're looking at, HIV prevention, adolescent sexual reproductive health services, we know, the barriers that, the younger groups face, from policy to societal attitudes to community norms that also come into play. So we also established that in terms of comparison of referral completion, turnaround time, was there any significance in terms of the turnaround time? And turnaround time is particularly significant because some of us are aware that HIV prevention services as well as ARCH services are very time sensitive, and therefore the turnaround time for service provision is particularly important. If someone wants to access PrEP, for example, it means that, you know, they need to access it where they feel that they are at high risk of HIV, of contracting HIV, or possibly, you know, there are higher chances. Or if someone with PEP, you know, we all know that is within 72 hours, and therefore the turnaround time is particularly significant because of the time sensitivity of the services that we are providing. We established that 47.2% of the girls and young women referred through the mHealth completed their service referral on the same day, compared to 0.8 for the paper-based system. The median time for referral completion was 1 day, you know, ranging between 0 and 9 days for mHealth, while it was 11 days for the paper-based system. Referral completion for mHealth was significantly higher than for paper-based system. Cox regression analysis showed a significant difference in the time to completion of the referral network between mHealth and the paper-based system, as represented on this graph. In terms of conclusion, compared to the paper-based system, the use of mHealth was more effective in reducing the turnaround time of referrals to completion amongst the target group, especially for HTS and ARCH services. And therefore, because of the good results that we have seen in the program in terms of improved access, linkage, and retention in service, we recommend that mHealth solutions should be scaled up in order to improve you know, access and adolescent girls and young women's access and linkage to HIV prevention and ARCH services. Thank you.
Thank you so much, Ms. Dominica, for the presentation. You took us to the application of mobile health tools and how it can help to make services more effective as well as efficient. So as we've come to the end of this talk, I want to also just thank our speakers once again for taking the time to share how mobile health is being used in their work. So the next thing, we're going to segue to our panel discussion. And before we begin, allow me to introduce our panelists who are from Desmond Tutu Health Foundation. So we have Leah Ogada, we as well as, sorry, for some reason, I think I'm having issues on my end. So sorry again. So allow me to introduce our panelists. We have Leah Ogada, and we have Victoria Warimu from Tigris, and Lauren Fain from the Desmond Tutu Health Foundation. So thanks to everyone. And I'm gonna, as I call on you, kindly turn on your videos. So and at this point, I'll also call on our two speakers to join us on our virtual stage. So Dr. Aoife as well as Ms. Dominica. So we're gonna start the questions or the panel discussion. Prior to that, I'm gonna check to see if we have any questions. And while we have the discussions, if you have questions, kindly put that in the chat. I guess you all can take it away. I do have a few questions, but I guess I'll let you start and then we can continue.
So I suppose as one of the first panelists, my name is Lauren Finn, and I was particularly interested in both of the presentations, but I was hoping each of you could speak a little bit more about the participants' burden. So I always am interested in, like, what was the cost burden to participants to utilize your applications? And I understand that in some cases it was a web app or a web page versus an application. Is that correct?
Sorry, with that last question, was that for me, Lauren, or was that for Dominica?
For both of you, just to clarify that one of you was a web page, and the one was a mobile application.
So in the Zimbabwe intervention, it was a mobile application. So if you're talking about monetary costs, there was none in theory, because they received the phone from us and they received data. There may have been some other costs, that they incurred, some time, obviously, but we tried to make cost not a barrier to their participation, if that makes sense. And the Y-check is still under development, so we haven't, it's not been implemented as yet.
Yeah, I guess, sorry to jump on. So just to build on that question, so thinking about the sustainability, I know you guys are still building it out. So in the long run, what are the plans for sustaining this?
For the Zimbabwe in particular, I think. Yeah.
Mm-hmm.
So originally we had wanted to use WhatsApp, which I suppose you could say might be more sustainable because a lot of people use WhatsApp anyway. But we faced some challenges in convincing people that we could do that safely with adolescents. So that's why we use this other platform. So I suppose we've done a feasibility study, and the next step for us, so recently completed, I would say. And so the next step for us is to think through what would the next stage model look like. Would it still use the same application, or would it be another application? And then how would that be financed? But I think it's a really good question, because if we can't provide the data and the data is expensive, then, young people will not be able to participate in that way. But I'd be interested to hear from other people's experiences in other interventions. There's lots of phone-based interventions. Like how are you all managing the financial side of things to allow people to participate?
Yeah, thank you so much. Yeah, no, I haven't figured that out. So that's why I was asking. I was curious about that because we have a project in Nigeria that uses a mobile app. And that's one of the challenges that we've had with having people use it, because data costs money. As young people, this is a cost that you're not trying to incur. Some of the things we've thought about, but still trying to figure out what that looks like in the long run, is using USSD codes. But we're still bearing the costs on our end. But how do we get to a point whereby it's like very minimal cost, or some sort of frugal innovation whereby they will always have access to it? But I'm going to end there. That way I'm not hijacking this discussion.
If I can just maybe interject and mention what we do in Triggerize. Thank you so much for the discussions. Personally, I'm also learning a lot. So in Triggerize, we have several ways for young people to interact with our platform. So we have WhatsApp, we have Facebook through social media. So we have Facebook. They can also enroll on our platform via SMS. And we of course, we foot the cost, so it's free for them, especially when they interact with the platform via SMS. They only need to send certain trigger words, which will trigger a response from the system and sort of guide them through the enrollment process, and also refer them to our nearby service providers as per their location. So this has worked really well, especially because most young people who do not have smartphones can also, but have feature phones, are able to enroll and get referrals through SMS and take service in as per where they are located. So that has really also worked out well for us. The other method that we use, or pathway, is through community health volunteers who we train. And for them, most of them, or rather all of them actually, that we have on our platform have smartphones. And they have an app which they can use to enroll a patient or a young person who does not necessarily have a phone. So we have cards that we call TICO cards. So this TICO card can be enrolled through the app, and once the enrollment is done, or registration is done rather, the girl is given the card, and this card is unique to her. This is how we identify her, and we're able to know when she gets a service. So that has also really worked out well for us, and I think it's a wonderful way to reach out to this population. Thank you.
Yeah, thank you so much,
If
Victor.
I,
Oh, yeah, sorry, Dominica, you can go ahead. I was just going to mention the question on the chat, but you can go ahead and respond to it.
Thank you very much. I'll respond to that question, but I just wanted to, the question of sustainability that you raised is a real key one, and our experience is the same as described by my colleagues in this platform, where we use a mobile app, we provide both the hardware and the software. So beyond the life of the program, it's very difficult for the young people to access. And in most of our countries, data is very, very expensive. And remember, we work with the most vulnerable girls. And for us, we have what we call a services referral network, SRN. These are the young people who are responsible for managing the referrals and supporting their peers to access services. So it is the SRN that gets the hardware and the software and uses the mobile app. But in terms of the question around, is there a general societal expectation that this age group should be married to access this service? This is so true. We still have significant challenges with healthcare workers' attitudes towards young people accessing adolescent sexual or reproductive health services. The policy frameworks also are not supportive for young people to freely access these services. And, generally, there are negative community norms. And what we have seen that really works, that has resulted in increased uptake of adolescent sexual reproductive health services, is where we do community-based service delivery, where we bring the services at a community level through nurses that have been trained, or service providers trained by the program. But young people still have challenges, going to a public health facility to access services. But what we have also done is that through the services referral network, on a monthly basis, they create a platform for dialogue between the young people and the service providers, or even taking young people to a health facility. Just going through touring a health facility, it has helped to debunk some of the fears that young people have around accessing services at a health facility. Thank you.
Yeah, thank you so much, Dominica. And thanks a lot, Lauren, for sharing this. So in the chat, you shared that zero rating is a technique where internet service providers allow consumers to utilize a specific website without charging them internet plan. I'm curious, does that work in every country? Do you have a sense of how it works? You could share a little bit more on that, Lauren.
So that's why I was like, it's country specific, and I was interested about whether your apps could be converted into web pages or accessible through a web page. Because like in South Africa, we have zero rating. I know that they have it in lots of European countries and in America, but you'd have to look at your infrastructure. And so I would be very specific about where and what access points you have for your apps, and they should still exist somewhere on like a larger platform like a web page, which is always nice.
Lovely, thank you. Any questions from the audience or speakers? Okay, so just curious, I think, so did anyone can respond to this? I guess just thinking about I think all of this is tied to also like recruitment and reach. Very often when you're thinking about HIV and sexual reproductive health research is usually a hard to reach population. So what are some of the strategies that you utilize to get a more diverse reach? Because one thing you had also mentioned, Dr. Doyle, in your presentation is thinking about diversity in the creation of such interventions. So I guess the question really is, how do you go about recruiting? So thinking about the reach and trying to get a diverse group of young people.
So in the Schwarzenegger project, it was, as you know, quite small scale, and the recruitment was in the community at hotspots where we knew young people hung out. So we did get a reasonable, diverse group of young people, mostly out of school, some in school. But I suppose, first you have to define who you want to reach, and then there's different ways. I think in terms of diversity, I liked what Victoria was saying, that, I think probably the most successful digital interventions might be those that cater for, have different modes of participation, like you mentioned, a Facebook page and a WhatsApp and SMS. And I think, maybe thinking along those lines is good, and maybe face-to-face as well, like in the example of Schwarzenegger, that maybe some sort of hybrid is a good idea. I do think for digital interventions, the sustainable and cost issues are big issues, but I also feel that potentially in the future, some of these costs will decrease, and now's the time to be developing and doing research on these kinds of interventions. Because we won't get it right the first time. It will take us a while, and hopefully by the time we do, we'll have got those costs down. But yeah, I think there's a couple of questions in the chat.
Yeah, thank you. Thank you so much. I guess before we take that, just looking at the group, I think we had a few people who had their hands raised. So Peter had his hand raised, and I think he's been there. Okay, take it away, Peter.
Yeah, thanks very much, everyone, for this presentation. It's really nice. My question relates to the selection bias. I'm trying to think the kind of people that you enrolled in the program in terms of their literacy levels, to really understand how the app works, to really know how to use the mobile phones, because I know there are people, yes, at some point maybe they may know how to use a mobile phone, but may not know how to use the app. Some may, be willing to understand in a local language. I don't know if the app and the directions were in a local language or translated in different languages and all that. So it speaks to the selection bias that maybe I want to hear from you. Thank you very much.
And Dominica, or if any of you can take that, or anyone else.
Yeah, thank you. I can take that. So that's a very good question, Peter. Thank you. So for example, for our services referral network, although these start off as beneficiaries of the program, but when we look for cadres, that can be part of the service deliveries system. Extending our own staff. We also use a certain criteria where we're looking for girls who can read and write, who are able to, communicate. Then we enhance their capacity, their technical capacity around how to do referrals, follow them up and complete. And therefore, definitely there is bias towards girls who, for example, we have a certain educational background, and some of them, could already have a mobile phone, but, not a smartphone, but they have some level of exposure. Thank you.
Thank you so much, Dominica. And anyone else can add to it. I guess what we're hearing is just the intentionality of the reach, because sometimes with our inclusion criteria, there's already an exclusion bit to it, so the bias of it, so being more intentional about the reach and also the diversity of our research. Because I think sometimes that's one of the challenges we have when we do have restrictions when you're thinking about how you're funded or depending on what the program is. But in all, we all have to be intentional about enhancing health equity without what the work we do, either research or programs. And we have Venice that has a question. Hi, Venice.
Hello, how are you? Thank you so much. I think my question is related to the one, Peter. We're looking at the findings from Dominica's presentation, where you're saying 47%, just over 47% of the clients that were referred through the mobile-based app were able to complete their service. Because I just wanted to find out how you then select your participants, and also because now the difference between that mobile-based and the paper-based, which is about 80%, it's quite a huge difference. So I wanted to actually find out the actual settings where the study would be carried out. Is it an urban setting? Is it a rural setting? And if it's a mixed setup, how are the results related to the setup where the study is carried out? Thank you.
Thank you very much for that question, Venus. So in terms of how the selection was done, remember I said we have a DHIS2 database. So it's just going to select in the database girls that have been referred to HIV testing services and adolescent sexual reproductive health. So it's selecting anyone who has such a referral, and where we are implementing is mostly in rural districts, except in Bulawayo and Gweru, but we do both urban and rural. And therefore, the settings are very rural, and we provide services via the public health sector, health facilities, as well as the outreach, that where we provide services as as a community. But for me, I think in rural settings, the paper-based system, it also depends on girls who are part of the SRN, the service referral network, working they have to walk to the service provider, to the client, and linking them. And that definitely takes time. But, because our service referral network is established around each rural health center, and therefore the service providers and the coverage, that's where we, the geographical coverage of a health facility, that's where we are picking girls who become part of the services referral network. So now with mobile phones or with a mobile app, even from the health facility or at community level, to say this girl has been profiled and requires 1-2 services, the communication is faster, and even following up whether the client finally went to access the service, that communication is faster as compared to a platform where you have to walk to the next village and remind a person to go and access their service, and also confirm with the service providers whether a particular individual accessed the service. So I think that's where the time difference is also coming from. Thank you.
Yeah, thank you so much, Dominica, for responding to that. And while you're on it, I'm just going to put you on the spot. You had a question for Dr. Doyle. Would you want me to read it out, or you would like to ask the question?
Yes, I can ask the question, and thank you again for your presentation. There are lots of lessons that we can draw from and even improve our own mHealth platform. But you kept on saying in your presentation, these digital platforms are not always the best for young people, and yet we, even in your earlier when you were giving us the statistics, it shows that the majority of young people have access to the internet and they are using it. And for us who are programming for adolescents and young people, we know that they obtain majority of their information from these platforms, from the internet. So as a service providers, if we do not go, to those platforms, do you think we'll have a better appreciation of their challenges, of their worldview to inform our interventions? Or we might end up just designing interventions that are not aligned to the young people's world? Thank you.
Thanks, Dominica. Great question. I like being challenged. I think what I was presenting there were trying to get a balanced view on digital health interventions and some of the recommendations that came out of that WHO report. But I think also some of the feedback that we'd received from young people when we did this small study of the Dhakwa intervention. I do think that we should explore all the digital options, and this is something I'm particularly interested in, as I'm sure all of us are on the call. But I think it relates a little bit to what one of the other participants mentioned, is that who are we reaching? And that right now, I don't know if if everyone is accessing digital in the way that we would like them to. So they may have access to a phone, but maybe if you remember the different A's, maybe they don't have the skills or the ability to really access some of the things we'd like them to access. So I guess my view is that we definitely need to go down the digital route, but we need to bear in mind who has access and who doesn't, and how that might be restricted. So if I share a phone with my mother, I may not want to go on a website and look up SRH information, for example. So I think, and then the cost and the network, I mean, it depends on your setting, but I think these are not unique challenges for, in just one part of one country. I think these are continual challenges that young people will face. So I think it's more just a cautionary, like a piece of advice for all of us, is that we should not just go digital, and that it is incorporating it into other programs and sort of having some balance there. But I mean, like I said, maybe in the future, that will be, hopefully, like everyone will have access in the way they want, but I don't think we're there right now. So I think that's where it was coming from. But I mean, for example, I think if I understand correctly, in your intervention, you still have a person who is that intermediary between your client and your service provider. So you're not just relying on the young person to have a phone and the service provider to have a phone. So it's already, in a way, you're using the digital, but you're also not just going digital, if I understood correctly. Yeah.
Okay, thank you so much. I think at this point, I wanted to check in with our panelists. Do you have any questions or just comments that we had on some of the presentations? Were there things that stuck out to you that you would like to highlight?
I wanted to say thank you to all of you, but also Veronica has possibly highlighted something that was important for us to voice as digital health within this field, to say that the only way we cannot leave anybody behind is to have all of these platform options. And so it's not only a matter of, a lot of our research is focused on at-risk populations, but the reality is that if we want to ensure that men and men who have sex with men, as well as young boys, they all engage on these platforms, we're going to have multiple options to facilitate that conversations across platforms. So, thank you.
Yeah, thank you so much, Lauren. I think that drives home the point of diversity, like we've mentioned, and also that one size does not fit all. So we need to start thinking about like segmented type of interventions for different groups to make sure we're meeting them at their point of need or what their preferences. So thinking about preferences for young people, because there are different groups of young people. So thinking about that as we develop our programs as well as interventions. So thank you so much for highlighting that.
If I can just follow up with what Lauren has mentioned, and what she said is very key, and it's also something that we are doing in Triggerize here in Kenya. When reaching out to the key populations, as she has mentioned, the men having sex with men, female sex workers, we realize that some of the interventions that we have might not fully work with this age group. Sorry, not age group, but this group, because here in Kenya, due to the societal norms and perceptions, they are very close group to reach. And what we've done is engage community-based organizations whose main focus is to support such people and reach out to them. So that is how we are reaching out to them here in Kenya at the moment. And at some point, we don't even attend their discussions. We just facilitate and get feedback for them to feel comfortable, because their number one need, as we are realizing, is the privacy, and they need to feel comfortable within the group of people that is around them. The other thing that struck me from this discussion is someone asked about the selection bias, and it took me back to the language that we use to reach out to our target audience, especially here in Kenya, different regions, considering different intellectual levels. So we did sort of an activity to just gauge the kind of messaging that we should have to reach out to young people, and we realized that it's vastly different. People understand things differently, and so it was for us to sort of curate the language as per the region that the target group is in, so that they're able to understand what we are trying to communicate in the simplest way possible, as according to how the language influence at the area where they are located is. So there's definitely a lot to be done in that. And there was also something that also came up, was how do we reach out to young people who are abled differently, those who can't hear, those who can't read, and are in need of these services, because clearly most probably maybe the technological aspect of it might not work so well. So that is also something to think about as we go about implementing these programs. Thank you.
Thank you so much, Victoria. I think one thing, what you've shared is quite profound. So just thinking, I think a lot about actually listening to who our target audience is, even if it's research or program, to make sure that we are accounting for what they want, and also meeting them, thinking about context and how that differs, and adapting interventions to meet their needs. And also one thing you had mentioned was differently abled individuals. I think when we're thinking about diversity, very often, this is a group that we always forget. We think about diversity from race, from sexual orientation, which is always important, but I think this needs to come up more in conversations. How do you include individuals to ensure that diversity goes beyond like our limited definition of what diversity is? So thank you so much for that. So we do have a question, and anyone can respond to this from either your research experience or from your programmatic experience. So the question is there sustained engagement with mobile applications, not just the cost, but thinking about fatigues, a lot of new application options or attention when not being supported or reminded. So basically, how do you give people engaged over time with mobile applications, so they don't get fatigued? And then is there research looking at sustaining e-health engagement outside the research setting? So I guess from research folks thinking about implementation, how do you integrate or translate this findings to real world settings? And for folks who have experience in programs, how do you go about developing your interventions, or selecting which ones you use in your program, and also how are those being sustained in those settings? So this is open to everyone, really. So from your experience, right, your thoughts on this?
Okay, go first. It's a great question. Thank you. I think the interventions that I've been involved in recently have not been intended to be long-term. So I suppose there's two ways to go. Some interventions are digital and are very short-lived. So maybe it's a one-off interaction or a one-off referral, or maybe it's over a period of time, like the Dhakwa intervention was 13 weeks. But one of the questions that we have now at the end of that sort of feasibility study, is that the right length of time? And it may be that actually a shorter length of time is required. And I think there was a little bit of fatigue towards the end of the intervention. So I think some of the digital interventions that exist out there for young people are not meant to be continuous over a long period of time. And if they are, then I think you're right. Like, there needs to be innovation. There needs to be something that catches people's eyes, because we know that, like, social media and the internet, it's all very fast moving. Something's trendy one week and then not the next. And so we need to, if we want people to sustain within health programs, for example, then we need to be as innovative and creative as the existing sort of commercial sites, I think. But that's a big ask. So I suppose it's thinking carefully about how long that engagement needs to be for. And in some cases, it's not necessary for it to be for a very long period of time.
Thank you so much. Any other thoughts on this, or from your experience when it comes to sustaining engagement?
So I suppose there's two ways to answer it. And in some ways, we've already highlighted the one that you really need to consider the aim of the app and what it's attempting to do. If it's an engagement, we have quite a few active apps actually that have to do with health outcomes. And if it's a simple matter of buzzing a reminder on your phone to wash your hands for the appropriate amount of time, then once that habit is built, you might not need the app again after a while. There are health tracking apps that are good for people, and that's dependent on what your possible outcome is as an individual. So if it is to lose weight, then until you reach your goal weight, then you might stop using it. And so in some ways, the aim actually is the intention of use is actually the indicator for how long it should be used. But in research, and in some of the research that we've done, we know that our adolescents particularly engage in apps, mobile apps, over long periods of time if they have somewhat of a gaming interface. And so the way in which the app looks and the way in which they engage, not only with their health information, but with each other on those apps, encourage them to sustain their own behavior. And so it's sometimes the things that we plug into as social assistants into the apps that make them sustain their use.
Thank you so much, Lauren. I haven't done this, but just thinking out loud, but I think just going back to the presentation by Aoife, just thinking about integrating into already existing platforms, because if you're thinking about continued engagement, if you have a tool that works, you can just incorporate this for your short period of time for whatever the intended use is, while this other part has the continuity. I don't have any specific example, but just thinking maybe for those of us that do research and programs, so if you thinking about sustained engagement and not just reinventing the wheel, you can leverage an already existing platform or application. Any other thoughts? I think we're coming closer to the end of wrapping up our questions. And from the audience, do we have any final questions, final burning questions? Feel like I need to ask this question so I can move forward with my work. Well. Looks like we have none. But before we wrap up, I really want to thank our speakers. Thank you so much, as well as our panelists. You all were phenomenal. We're very grateful for your time. And we also want to thank the artists who performed. I don't know about you, I really loved it. I always think about like alternative ways of communicating health. So for me, that was pretty powerful. And I would also like to acknowledge Desmond Chichu Health Foundation for sponsoring this event, as well as the International AIDS Vaccine Initiative. And also with the rest of you that joined, thank you so much for your time. We really appreciate you all joining. And I hope we all learned from this. And I think at the end, the presentations will be available to everyone. So thank you so much. And have a great rest of your day or evening, wherever you are. And also, I think one last housekeeping information. As you're trying to log out, you probably get a prompt to complete a form or a questionnaire. Please kindly do that. It's always helpful to get feedback on how to improve. So thank you so much, everyone. And I hope you learned a lot today. I did. Well, thank you.
Thank you. Bye-bye.
Bye.
Thank you and goodbye.
Bye.